Welcome to the Inside the Boards Study Smarter series, dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed on your exam.
Welcome to the Inside the Boards Study Smarter series for the USMLE Step 1. It's 2019 and we're doing this again. Today it's me and Stuart. Stuart, how are you?
I'm doing great. Thriving here.
Thriving? Wow,
Thriving.
That's great. I like to hear that.
Yeah, man.
I'm thriving too, even though today's my birthday and I'm now even older.
Happy birthday.
Oh, thanks.
We'll have to go grab a brew after this.
Yeah, that'd be nice.
Virtual brew.
I guess I can go drive. Well, it's probably nice where you live, but here it is variable in Ohio. All right, before we get into this, I just want to tell everyone, stick around at the end for the announcements. I am giving you guys a break from all that stuff today because we got a review on April 13th by somebody named Abramaz. I don't know how to pronounce that, but the reviewer said, I started listening to you guys today and I really liked the medical content. All right, yeah, thumbs up. But I don't think I'll be able to take 3 to 4 times per episode of mentioning the new Qbank. In 2 episodes, about 30% of the total time was about the Qbank. Know your audience, medical students, or decision makers, so mentioning it 1 time per episode is more than enough. I will keep checking 1 time per week to know if you fixed that or not, to know if I will continue listening or not. Well, Abramos, thank you for that feedback. Yes, we are excited about our Audio Qbank, but we'll keep it to a minimum for this one. I was just so excited because we've been working on it for way longer than I had planned. But yes, please keep listening and telling your friends. So today we'll get into the content toot sweet. We're going to do some ID stuff today?
We'll start there, I guess.
I'll take this first one, and these questions are brought to you by Exam Circle. They are the provider for our Step 1 Audio Qbank. Oh, crap, I just mentioned it twice. Hopefully that's not too bad. So go over to examcircle.com. It's actually a free Audio Qbank that is crowdsourced, and their model of question writing is, I think, at least has the potential to really find the highest yield content to be included in a Qbank. So examcircle.com, it's free, sign up, help contribute. All right. A 25-year-old male presents to the emergency room complaining of fevers, vomiting, headache, and muscle aches. He reports 2 weeks ago he went on a hunting trip where he shot and killed a bear. Oh, nice. He brought several pounds of the meat home and consumed them. Laboratory workup reveals a significant eosinophilia, and a muscle biopsy confirms the diagnosis. He started on the first-line therapy for his condition. Which of the following medications shares a similar mechanism of action to this patient's current treatment regimen? I was thinking we'd start with kind of a standard framework of approaching these. I tend to just read the vignette all the way through, but maybe what we'll start doing is doing this kind of 4-step process where we look at the interrogatory first. So that's which of the following medications shares a similar mechanism of action to this patient's current treatment regimen. All right. Next, read the vignette. Next, summarize the vignette. So in your own words. So
guy kills bear, eats bear, gets sick.
Yeah. And he's sick with an eosinophilia, and he started on a medication that treats the condition that is not named, of course. So then we get to our answer choices. A is ivermectin, B is colchicine, C is metronidazole, and D is diethylcarbamazine.
This is kind of a tough one. They're not making it easy for you. So we don't know. I mean, assuming you just read this off the cuff, you might not know the diagnosis. You could probably tell from the eosinophilia, they probably have some sort of parasitic infection, and the muscle biopsy may be a giveaway for you because that confirms the diagnosis here. After that,
and there's very few things for which a muscle biopsy confirms the diagnosis.
Right, exactly. And then even if you know that, this is trichinosis, maybe. That's my guess based on that. Which you get from like eating things like uncooked pork and stuff like that. I guess the bear meat is just a weird way of going toward
Weird
that.
way of doing it.
Not classic, but I don't know enough about bear meat, to really comment on whether or not it might have trichinella. But regardless, it asks you what medication has a similar mechanism, right? So we treat trichinosis with albendazole, right?
Mm-hmm.
That's like a microtubule destabilizer. Gosh, I hate step 1. So it basically makes it so that the parasites cannot really have good motility, right? What other drugs kind of inhibit motility that you can think of?
The other bendazoles like albendazole and colchicine.
Yeah. So really, colchicine kind of acts very similarly, except instead of with like the parasitic organisms, it's acting on your own neutrophils. Usually we use that for anti-inflammatory, like gout treatment, right? So it's a really interesting way to go about it. The other things that are going to affect like microtubules are things like antifungals or like griseofulvin, and then the classic ones that you got to know for step 1 are going to be the like vinca alkaloids and the Taxol drugs, right? Those kind of either destabilize microtubules or actually overstabilize them so they can't be broken down, and then the cancer is killed with that, right?
Yeah. I think this question illustrates something important. So imagine yourself 6 hours into step 1. You've run out of break time because you had to cry for half an hour's worth of time. And you have to go to this block, and it's, the end of that block, and you're facing your final block, and you read this question. You're like, okay, 25-year-old dude, eats some bear meat or any meat, all of a sudden has an eosinophilia and muscle pain, and he started on a first-line therapy for his condition. And then this interrogatory is so long, so I'm probably thinking in my mind, what's the treatment? It's probably a parasite because the eosinophilia. I bet the answer is ivermectin because that's an anti-parasitic medication.
Boom.
But
got it.
But
no.
You'd be wrong. You'd be wrong because you didn't pay attention. So this one is which medication shares a similar mechanism of action to that first-line treatment. So the first-line treatment we have to know first we have to know the diagnosis, the most likely diagnosis, which is trichinella. And then we have to know the first-line treatment, which is albendazole. And then we have to know in general the mechanism of action that's, acts on microtubules and prevents microtubule building, construction, whatever, and parasites. And then we have to know, too, that colchicine does something similar by binding to tubulin, inhibiting microtubule polymerization in neutrophils to produce an anti-inflammatory effect. So, I don't know. This question seems simple, but it could be kind of tough.
I think it's a little unfair not telling you that we treated this with albendazole. Just saying the first line therapy. I mean, you never know what they might do on step 1, but I don't think they would tell you that they didn't use albendazole here, unless this was one of those like 290 questions, where you're not supposed to know. I don't think it's really that fair to not tell you. And then to kind of talk about your point about like, what's the treatment? Oh, here's a anti-parasitic drug here and here. And the way that you kind of get around that, I found helpful with these tests are when you see there are 2 drugs that might do that same thing. So there's ivermectin, which is an anti-helminth, and there's also diethylcarbamazine, which is also an anti-helminth. If you see the 2 and, it could be that they want you to pick like the best treatment, in which case that would be a different kind of question here. But when you see multiple drugs that might potentially be useful here, that kind of points you in a different direction. Classically, I had a question recently about lead poisoning, and they wanted to know like what was the next step in management. And they gave me 3 chelating drugs, and then they had 2 other answer choices. And I was like,
deferoxamine?
They had deferoxamine, dimercurol, and like EDTA. Or like dimercurosuximor or something like that. I forget their names. Not important. I'm not going to deal with that. I can read them.
Actually, it's totally important. You should probably know those. Ignore Stuart on that point, but we don't want to overwhelm you with information. We
exactly.
want you to be able to take something with you from this episode and bring it to your exam center on test day.
Right. But the point being, they had 3 of them, and I was like, oh goodness, which of these 3, like, are they getting at like which one is the better one? I ultimately didn't end up picking any of them, because it was like a very sly question where it just wanted you to double check that their lead level was actually elevated. But that was a reason to like be weary of picking one. It's because all of those answers were like actual ways of treating the lead poisoning, right?
Steps in management of treating lead poisoning.
Mm-hmm.
Gotcha. So just to summarize, part of this vignette did not include some of the classic associations with trichinella explicitly. So you see myalgias and periorbital edema in somebody who ate undercooked meat. That's going to be your classic setup for trichinella. Another one of my favorite couple parasite facts that you want to keep straight are the liver Hydatid cysts. Do you know what that's in?
Oh,
what organism?
The no, I'm blanking on it right now.
Echinococcus granulosus.
Echinococcus, right?
Yeah, I just like to say that one. All right, what about hematuria associated with squamous cell bladder cancer? Parasite.
I think of like strongyloides there. No.
I mean, I guess, honestly, I don't know. Maybe it could, but the one that shows up in the review books, schistosoma hematobium.
Schistosoma. Sorry. Strongyloides. Yeah, schistosoma. Bladder. Sorry. That's just the wrong.
That one's easier, though, because it's bladder, bleeding bladder, hematobium, right? He should bring up the idea of blood. And then how about seizures and a brain cyst?
Ooh. Like cysticercosis?
Yep. Do you know what the organism's name is?
Oh, I always forget these things. No, I don't know. I don't know ID.
Solium. Tinea solium.
The solium.
That's okay. I actually prepared notes on this one. Trying to show you up.
That's okay. This is how pimping works.
Such an enjoyable pedagogical method within medicine.
It's lovely.
You want to take the next one, which is number 4 on our list?
So let's change it up a little bit here. You want to read it backwards like we were talking about?
Yeah, let's try to
let's see.
To that.
Let's see what you guys think about this, because it's a little different way of approaching the question, and it kind of, I kind of feel like we talk about doing it this way, and then when we read it normally, like I feel like everyone's sitting there like kind of banging their fist, or I would be at least. But
in the last episode, I said I was going to try to stick to this 4-step framework like I mentioned above, but let me just explicate it as a reminder again. 1, read your interrogatory first. Next, read your vignette. Keep your answers covered. Don't look yet. Next, this is number 3, summarize the vignette in your own words, highlighting the, pertinent positives or negatives. And then 4, try to come up with an answer to that interrogatory that is that you come to without looking at the answer choices, because each board question should cover the satisfy the cover the answer choices criterion, which basically means you can come up with an answer without actually looking at the answer choices. Now, that doesn't mean that if you come up with an answer that may be appropriate, that it's going to be the one that's listed, because one way of making a question more or less difficult is to pick one treatment amongst 4 acceptable ones and only including one, and the rest being things that aren't treatments, for instance. So yeah, let's try that.
I'll give it a shot. Okay, so just to throw us off a little bit, what pathologic process describes the formation of these lesions? So we know we're talking about some process here. So we have a 27-year-old male who is a known IV drug user who presents to the ED with shortness of breath. He's difficult to arouse and intermittently responsive to questions. He's febrile,
he's like a medical student.
Classic, right? Difficult to arouse, intermittently responsive to questions. In the way, he's febrile, tachycardic with a blood pressure of 108/76. His respirations are 10. On exam, there are lesions on his nails as well as fingertips and toes. When these lesions are palpated, he withdraws vigorously. All right, again, what pathological process describes the formation of these lesions? Is it?
Whoa, not yet.
Ooh.
Yeah, see, it's hard to break our habits.
Yeah.
All right, so you read that first, and you read the vignette.
So
let's summarize what we have.
We have a drug user who has things in there.
More properly, a person who has a substance use disorder. I mean, I've told you I want to go back and do, if I can get enough money, or once my wife becomes an attending, I'm going to go back and do an addiction fellowship, I think.
Oh, yeah.
Thinking about it.
Just redo it all. Start over. So a substance use disorder.
Thank you.
Sure. If you say so. Maybe they just like to do IV drugs occasionally. You never know. This could still happen. Anyway, then they're probably under the influence right now. And then they have lesions in their fingers and toenails, right?
Yeah. Sounds like...
they're painful, apparently, because he withdraws vigorously.
Yeah, sounds like he's got endocarditis.
I don't know if we need more information than that. In fact, that's kind of the beauty of these questions, or these, when you read the interrogative and you're like, what pathological process describes the formation of these lesions? If you know exactly, that's clearly directing you to the lesions. Oh, the lesions on his nails, fingertips, and toes that
and
are painful.
The pathologic process? It's endocarditis. So,
so right, we know where we are.
I have an answer in mind. Just kidding. I don't have an answer for the cover of the answer test on this one. I would have to probably look at the answer choices.
You say endocarditis, and why endocarditis?
Well, because these lesions are whatchamacallit, Osler nodes.
Janeway lesions, Roth spots, Osler nodes, those things. Splinter hemorrhages.
We should explain the difference amongst those before ending this question, but is it septic emboli?
We never read the answer choices, so let's do that then.
All right.
We're concerned that they have endocarditis because they're a drug user and they have these lesions, and this is just a classic setup. So we have, is it deposition of immune complexes on subsequent inflammatory response, septic emboli, spontaneous capillary hemorrhage, or external trauma, right?
Mm-hmm. Well, one of my answer choices is there. Septic emboli. But they're painful. I mean, my problem here is I don't really remember the difference between Osler nodes and Janeway lesions. Well, and really the pathophysiology of those things.
Right.
So maybe help me out on this one.
So Janeway lesions, they're non-tender for starters, but they're just little like red spots that kind of like, I think of them as like tracking up the palms like of the hand, which are a little different from Osler nodes in the fact that Osler nodes are actually painful and kind of more in the fingertips.
Okay.
They're like these painful red lesions, right? Now, both are kind of coming from very similar, like you get this reddening and erythema there, but the difference here is these being painful makes them Osler nodes, right? Instead of Janeway lesions. And Osler nodes are painful because they have a inflammatory response, and that inflammatory response is related to immune complex deposition, which is a deposition of immune complexes and subsequent inflammatory response. So you were like, all right, IV drug user, we've got septic emboli, right? And you're right. They probably do. It's just not what they're describing here.
Okay.
You're thinking of like the like splinter hemorrhages and little pain at like the tips of the fingers, right? Which is just a very similar finding. And you can almost like lump all these together and say that because they are all occurring in the hand, there's probably just like one thing, but there's just a couple subtle distinctions here. So I mentioned the Osler nodes. That's what they're describing here as painful erythematous lesions, where the Janeway lesions are more just erythematous but non-tender. Another thing,
you know what? I think I would remember Osler nodes as painful, probably by saying, if they have an Osler node, what comes next? Well, O in the alphabet, then P. So Osler painful. I don't know if that works though, because it depends on how you remember the opposite of painful. Non-painful is probably how I would do it. Because, of course, painless also begins with a P. I don't know, though. Maybe talking about that as Osler nodes painful is helpful, but they're both on the extremities, which always, I think, confuse me. But the Janeway lesions you said are painless. Those are on the palms and soles, and Osler nodes, are they more properly on the fingers themselves or the pads of the toes or whatever?
I think of both of them in the hand. Yeah, I don't distinguish them as like tips of the fingers or anything. The Osler nodes being inflammatory is kind of the easy way to pick them with an inflammatory response is painful for me. So that's how I would remember that. That's not particularly helpful though, because if you really look into like how Janeway lesions develop, I think they're kind of, they are septic emboli causing like little micro abscesses in the skin. And I would think of that as painful, but they're considered non-tender. So there's some sort of voodoo magic there that I don't want to confuse the listeners with.
Is it that you don't want to confuse them?
Or I don't understand it either. Yeah.
Come on, let's be honest. But then again, you don't have to know everything to get these questions right. So, all right.
Yeah, that's the problem with step one is you do have to know everything to get it right.
What about the mnemonic from Jane? Yep, these are the common findings associated with infective endocarditis. It's an acronym.
Ooh, okay. So I can't think of F right now, but O is probably the
Fever.
Osler nodes. Okay. Fever,
Roth
Osler
spots.
nodes, Roth spots, and Janeway lesions.
Murmur.
Oh, I forgot an M. I just said
Yeah,
for Jane.
From Jane.
From Jane.
Anemia, nail bed hemorrhages, and emboli.
I like it.
All right, before moving on, let's mention that thing about the number one cause for acute endocarditis is what bug?
Oh, I thought you were going to go with like drug use. So it's going to be like, it's going to be staph, right? From drug use.
Staph aureus. And then what about subacute endocarditis?
Oh, we're going to think about, that's going to be viridans or like a strep mutans bug.
Yep.
Classically.
Streptococci.
Classically, they just had some like dental work done, or they have really bad oral hygiene. And then there's the like one you have to like, for some reason we love this. I guess we love this relationship between strep bovis and colon cancer. So that's like another one to look out for if you see an older gentleman who hasn't had like recent dental work or something, and they're found to have endocarditis, and it comes back as a strep bug. Consider doing a colonoscopy.
Okay, that's I did not know that one. That's good.
Right. It's an interesting association, and that's why I think it's testable. It's more step 2. Absolutely. That's getting away from step 1, though.
Murmurs. So, which valve is most likely or most commonly involved in endocarditis, bacterial endocarditis?
It's going to be a tricuspid murmur.
So that's in IV drug use, right?
Yes.
Let me restate that. It's overall the valve most commonly involved in endocarditis is the mitral valve. But
yes,
if you have a tricuspid new onset, like tricuspid murmur or vegetation on the tricuspid valve, you can take it to the bank that the person has a substance use disorder.
Ooh.
IV drugs.
Ooh.
Is that better?
It's close. There's one instance I'll throw out where it's not the case.
Okay.
Yeah.
Give it to me.
No. You called me out on my tricuspid. I just like jumped to endocarditis being IV drug use all the time. You might have tricuspid or pulmonic valve involvement with metastatic carcinoid.
Yeah.
For some reason, the excess serotonin can lead to a inflammatory or like deposition on those valves and lead to a murmur there.
Okay. Am I supposed to know that? I probably don't have to know it.
I don't know if you need it anymore.
I think I've had 3 patients in the past 7 years who had endocarditis pregnant, but man, they got really sick. But it's disappointing. They didn't have some of the Janeway Osler Nodes findings. Probably not disappointing for them, but disappointing from I would like to see this standpoint.
Oh yeah. I mean, the fact is like a lot of these are like question worthy material where you may not see it in real life just because we typically try to catch things earlier than they, before they become really bad. Like tertiary syphilis, you're not going to be, hopefully, you would be in a really interesting situation where you see tertiary syphilis.
First patient I ever saw on my geriatric psychiatry, first rotation, first day, tertiary syphilis. I was like, oh man, 3rd year is going to be awesome.
Yeah.
It got a little more quotidian after that.
Gotcha. But yeah, the other situation, but it would be like carcinoid. But you got it. IV drug use is definitely going to be more common.
All right. So as promised before, though, here are our announcements for this episode. Now, I know some of you want to turn this off, specifically probably at Abramos, I don't know. But I hope you don't, because I'd like you to hear my appeal and offer. So number 1, we will pay for your USMLE or COMLEX registration fee. We're running a contest now over the course of 3 months, and the top 3 winners who earn enough points, which I'll get to in a second, will be entered into a drawing at the end of 3 months to have their USMLE or COMLEX exam registration fee paid for, thanks to physicianloans.com. During this contest, you earn points for doing certain actions like leaving a review on iTunes. So Abramouse would have already got 1 point or 2 points, however that's set up. I can't remember. Next, we're doing kind of lifestyle encouragement things. So we are granting points as well for you doing the things you probably normally do or feel like you ought to do to have work-life balance. So if you're out exercising, or you decide to make a healthy meal, or take a break intentionally from study to watch Game of Thrones, unlike Stuart did, where he watched Game of Thrones for days on end during his Step 1 study. You do things like that, post proof of it in some sense via photo or video on Instagram, tag us at InsideTheBoards, and then use the hashtag #ListenLearnLive. This is kind of the framework or rubric around which we're building Inside the Boards, because if you have listened to us, you probably notice we try to encourage not only you to study and do better or as well as you can on your board exams, but also to put it in the perspective of the broader context of your life, because truly, your life is more than just medical school. You will not be able to be a good doctor. You will not be able to, quote Lincoln Osiris from Tropic Thunder, survive if you do not have balance in your life. So we want to encourage that. Basically, then, you do the things you normally do, but post the proof on social media and then help us out if you find our content useful by sharing episodes, things like that. And you could get different prizes like subscriptions to our All-Audio Qbank, or the ultimate grand prize, your USMLE COMLEX registration fee. It's over a $600 value. And again, thanks Physician Loans, because we could not afford to pay that right now. At any rate, there's announcement number 1. Announcement number 2, please go download our iOS beta app and give us feedback. Use the meditations in there, again, as another part of the live component of our Listen, Learn, Live framework. Help you kind of de-stress during med school. They're free, so you can save a few bucks on, if you've already exhausted your headspace, save a few bucks on your headspace subscription, or I don't know. I have no idea what I'm saying. I'm just going to leave it here, though. All right, so that's the end. All right, we'll see you back next time. It's the Step 1 Study Smarter series.